Thank you, Barbara, and it's a pleasure to be here with you today, and it's been a great deal of fun working with the Planning Committee, so I appreciated their invitation to talk with you on what defines a special nutritional requirement. I have a few disclosures which you can take a look at, and I want to talk about the objectives for the next 20 minutes. So one objective is to overview the dietary reference intakes and their specification. For many of you, this will be a review. I want to talk a little bit about nutritional kinetics and dynamics relative to the requirements, and then move into special nutritional requirements in diseased populations and approach this as an evolution from distinctive nutritional requirements. As you heard Dr. Schneemann say, that is defined within FDA regulations. And also then think about the possible relationships of DRIs with special nutritional requirements. And conclude with a little bit about challenges as well. So the traditional DRI, and I'm framing it this way because I'm not going to speak about the recommendations of the guidelines for considering chronic disease endpoints, which propose another way of looking at this in addition to the traditional DRIs. But the traditional DRIs really reflect a distribution of requirements and risk of adverse outcomes in a healthy population. And you'll notice healthy is in quotes, and Dr. Schneemann's already alluded to the fact that there are questions and controversies about what constitutes healthy when your general population contains a fairly substantive prevalence of chronic disease. But in this distribution then, as intakes are low, the risk of adverse outcomes increases. As intakes begin to increase, you have an area where the risk of adverse outcomes is minimal, and then at higher intakes, the risk of adverse outcomes begins to increase. And we basically set the recommended dietary allowances at a level of intake that meets the needs of 2.5% of the general population. And we define an estimated average requirement, an EAR, as that intake that meets the needs of 50% of the population. And we define tolerable upper levels for those nutrients at which above that intake on a chronic basis leads to adverse outcome. So within this framework, intakes at or above the RDA and below the upper level constitute an adequate and safe intake for healthy populations. Nested within this, and another way of looking at this distribution, is the U-shaped curve that you see nested, where the estimated average requirement meets the needs of 50% of the population, and the RDA meets the needs of 97.5% of the population. And I think that's important to think about this framing in terms of how these distributions relate to each other. Our current process for setting dietary reference intakes is in the risk assessment framework, and I've chosen to use language that is not from the toxicological risk assessment framework. So those of you very familiar with hazard identification are going health outcome identification. But what this means is within the context of setting a DRI, you must identify a health outcome because you're looking at the risk of that health outcome occurring. And this is done through systematic and additional literature reviews. And causality is important in this relationship. Once a health outcome or outcomes are identified, then assessing the dose response is important for setting the reference value. Additional steps in the DRI process look at the assessment of intakes in the population and risk characterization. But the two primary ones that we're going to focus on today are the identification of health outcomes and dose response assessment. Now, the traditional DRI in health outcome identification from 1997 to present, most of the DRIs were set to prevent deficiency, and examples of this exist for thiamine, vitamin B6, and a host of other nutrients. For two nutrients, at least consideration of prevention of chronic disease endpoints was included in the specification of the DRI, and these include fiber and vitamin D. And beginning with vitamin D and calcium, there was an incorporation of systematic reviews in 2011, and shown here is a generic analytic framework for looking at how exposure or intake of the nutrient directly or through valid surrogate endpoints or indicator markers relate to clinical outcomes. And this frames then how the evidence is reviewed and the selection of the health outcome indicator. And there are a number of challenges that are faced in doing this, whichever nutrient is under consideration. And the Tufts Evidence-Based Practice Center and others identified some of these challenges. And part of this surrounds how do you select which health outcome is critical and which one will be used for establishing the nutrient reference intakes. One question is how to choose the one of most value. And I think as we move into special nutritional requirements, this is an important one for you to keep in mind because, in fact, the health outcome for a special nutrient requirement for a specific disease population may well differ from the health outcome chosen for a generally healthy population. And that's a challenge. How to decide which outcomes, designs, populations, et cetera, are of limited value. In other words, how to focus your body of evidence that will be reviewed. And again, this is relevant to how diseased populations will be considered. Systematic reviews are done well when a technical expert panel is involved, and that's essential to the selection of outcomes. But the prioritization and the view of the outcomes might differ with different experts on the panel. And that's something that has yet been fully addressed as to how do you minimize those differences and thus reduce bias in the review of the evidence. One thing that the Tufts Evidence-Based Practice Center suggested was establishing instructions on how to weigh outcomes to eliminate variability in how they're considered. And this might well be useful in special nutritional requirements, but gets very complicated as it might differ for different diseased populations. And that is a challenge. And they also suggested that the use of an evidence map to understand the nature of the body of the evidence. Is it observational? Is it clinical trials? Are there mechanistic studies? Is biological plausibility shown? Might also be helpful. So in this process of looking at health outcome identification, the estimated average requirement and the recommended dietary allowance of need are usually based on the same health outcome because the estimated average requirement is, if it can be specified, is specified, and then the recommended dietary allowance is set at 2 standard deviations above this estimated average. When an estimated average requirement can't be established, an adequate intake is established, which is uncertain as to how it relates to the distribution of requirement, but generally meets the needs of most of the population. The upper level, however, is often based on a different health outcome than the estimated average requirement in the RDA, and a more cautious approach is taken in looking at the evidence. The strength of the evidence is sometimes less because causality is difficult to understand, difficult to establish sometimes. I don't know about your IRBs, but the ones that I'm familiar with seldom view favorably a randomized clinical trial in which you're going to recruit people to study toxicity. And so that just doesn't happen. And that's recognized. So we're left with this distribution of requirement in a generally healthy population. And I think an important question for us then is what causes this variability in requirement? And we intuitively understand this, but we don't often enumerate it. And that's what I want to do next in the framework of a kinetic and dynamic model. So nutrient intakes. Nutrients are consumed. There's a kinetic set of processes that result in a nutrient concentration at the site of action, and they're dynamic processes that result in the nutrient action at that site. These kinetic processes include absorption, digestion, the bioavailability. They include distribution in terms of the volume and the compartments in which the nutrient is distributed, metabolism, and excretion at a minimum. The dynamic processes include actions of the nutrient at the site, which relate to dose response and effect, maximal efficacy, and the temporal response, which we often don't consider but could be quite important. They also relate to adverse effects in terms of dose response at the site of action, deficiency and toxicity, and temporal responses. And they relate to inflammatory responses. Think about vitamin D and iron, to name a few, and there are many others. So the variability among individuals in these kinetic and dynamic processes relate to a number of factors. Genetics is certainly one. Epigenetics is another, and an important one, and can be transgenerational. Age is another one that over the life course can change the kinetics or dynamics in an individual. Sex, the physiological state, whether the individual is growing, pregnant, lactating, or other physiological states. Nutrient diet interactions, including bioactive components, nutrient environmental interactions, and dose drug nutrient interactions can all influence this process in a generally healthy population. And that brings us to the important factor for today's discussion, which is disease state. And that's an important consideration that can affect the kinetics and dynamics of nutritional requirements. And Dr. Stover is going to talk much more about the biological processes that underlie this in his talk. Which brings us to distinctive nutritional requirements, and you've already heard that medical food is not the focus. I'm bringing this up because this is where distinctive nutritional requirements is defined. And medical foods are intended to meet distinctive nutritional requirements of a diseased population. And I want to point out that in the definition, it's focused on nutritional kinetics. So it focuses on patients who, because of therapeutic or chronic medical needs, have limited or impaired capacity to ingest, digest, absorb, metabolize ordinary foodstuffs or certain nutrients, and who have other special medical determined nutritional needs in terms of dietary management. The dynamic part of the processes are not explicitly focused upon in this definition, and yet could be quite relevant in diseased populations. In fact, distinctive nutritional requirements are narrowly defined by the FDA, and this definition explicitly excludes the chronic conditions. I don't know that I would consider pregnancy a condition, but be that as it may, they exclude pregnancy, they exclude diabetes, and they exclude nutrient deficiency because these can be met with modification of the diet. And so what I want to do next is give some examples of how diseased populations' nutritional requirements might differ from the distribution of nutrient need in a generally healthy population. And I want to focus on PKU as an example where that need cannot be met by modification of a typical diet. And so what happens is, because of the deficiency of phenylalanine hydroxylase, there is an alteration in phenylalanine metabolism that one can think of as resulting in a lower upper level for ingestion of phenylalanine. It's not the only way one can think about it, but it's one way to think about it. Relative to the distribution, you have a markedly lower upper level. And I drew this, I see Dr. Ney sitting there looking at it. I drew this just simply for the point of explanation. I'm not trying to say it's accurate or that it relates to the EAR. I just want to put that in the record there. A different example of a chronic disease is cystic fibrosis, where in fact the kinetic impact might be met by diet modification and can be. And here, because of the impairment in digestion in most individuals with cystic fibrosis, there is an increase in the need for fat-soluble vitamins. And this need can be met by supplements and by modifications to the diet. But shown here is, again, just for explanation. If there are any cystic fibrosis experts in the field, I'm not trying to suggest this is exactly what it looks like. It's just an example, in which you have an alteration, a shift to the right, a need for higher intakes, and a shift in the amount that would be needed for meeting the nutritional needs of this population. So when we come to distinctive nutritional challenges, one of the challenges I think is regulatory, in that it's currently included in the definition of medical foods. So it's linked to treatment. and not by modification of the diet. And I understand that definition, but it brings us to how we've evolved to considering special nutritional requirements. And I'm going to be so bold as to propose that this is a distribution of nutritional requirements for a specific diseased population outside of the DRI distribution for healthy populations. And the evidence needed to determine if the distribution of requirement for diseased population differs from that for the distribution for generally healthy populations is going to be discussed at length. I want to touch on a few points here. You need to understand the mechanism for the altered requirement. Is it kinetic, dynamic, system-wide, tissue-specific, or some combination thereof? Are biomarkers of effect, i.e. dynamic, important? And what are the challenges of using biomarkers? And Dr. Stover and others are going to discuss this. Do you need systemic biomarkers? Do you need specific tissue biomarkers? And what is the distribution of the requirement in diseased individuals relative to the DRI requirement? So what constitutes a distribution outside the DRI? Shown in green here, again, as an example, is a disease distribution that might fall within the DRIs, and that's perfectly reasonable and could happen. So it doesn't constitute necessarily a special nutritional requirement. In contrast, you might have distribution requirements that are higher and require a higher recommended allowance, or you might have distribution of requirements that are lower and require a lower recommended dietary allowance. And that is all possible and needs to be determined for each. So in the issue of special nutritional requirements, it becomes very important, these first two steps. The first step relative to special nutritional requirements is identifying the health outcome related to disease using systematic reviews and additional literature reviews, and focusing either on management or nutritional treatment of the disease. And from that step, then using that disease-specific outcome, I'm going to posit to you that you need to assess the dose response for that outcome in that specific disease population, and you need to compare it to the DRI distribution for generally healthy populations and demonstrate that it differs. I think an additional challenge here then is going to be, how do you compare the distribution of a dose response for a special nutritional requirement if the health outcome for that diseased population is a different health outcome than for the generally healthy population? And I have no answer to that, and I'm looking forward to the discussion through this workshop for some better understanding of that. And with that, I want to just summarize the key points here. Special nutritional requirements are for specific disease population. They contrast with DRIs that are set for generally healthy populations. To be a special nutritional requirement, the distribution of requirement in the diseased population must differ from that in the generally healthy population, either because of kinetic or dynamic effects of the disease on the nutrient, the needs to manage that disease, the effects of the nutrient on disease processes, and the identified health outcome may differ from that selected for the DRI for the generally healthy population. The DRIs for generally healthy populations are intended to prevent nutritional deficiency or toxicity or prevent chronic disease, and for special nutritional requirement, either systemic or tissue-specific deficiency or toxicity needs related to the pathophysiology or management of the disease are what drive the special nutritional requirement. And with that, thank you very much.